Most acute pain conditions can be treated with over-the-counter medication such as ibuprofen and paracetamol. Unfortunately, chronic and neuropathic pain cannot be as easily managed with such medication due to the more complex nature of the condition. Those with chronic or neuropathic pain conditions often follow a multidisciplinary approach, whereby they use a combination of various treatment approaches available to them. These include pharmacological, electrical stimulation, and cognitive approaches. Pharmacological methods, or in other words, pain medication, used to treat acute pain generally target inflammatory mediators involved in pain transmission, or receptors that stimulate the body's own mechanisms of pain relief. Typically, those with acute pain will often take non-steroidal anti-inflammatory drugs like ibuprofen, which is found over the counter. Inflammatory mediators, such as prostaglandins, are typically released during an acute pain response and where tissue damage may have occurred. Non-steroidal anti-inflammatories inhibit the COX enzyme, specifically COX-2, which inhibits prostaglandin synthesis. This prevents the rise in body temperature, vasodilation, and more. These drugs are sufficient in treating acute pain, but are rarely used to treat chronic or neuropathic pain, as they fail to treat the underlying physiological dysfunction, the complex inflammatory pain, and are not good for you to take for long periods of time. Those with chronic or neuropathic pain often take stronger medication due to the complex nature of their conditions. An example of stronger medication would be opioids, like morphine. Opioids are able to bind to opioid receptors, specifically the mu-opioid receptor, to stimulate endogenous opioid production, specifically the release of inhibitory neurotransmitter serotonin and GABA. Serotonin and GABA will inhibit the pain response upon release by producing analgesia and euphoria. Opioids are considered one of the most effective medication in the treatment and management of pain. However, its limitations include dependence and tolerance, whereby you need an increased dose to maintain an effect. There are also other problems and side effects, such as central nervous system and respiratory depression and opioid-induced constipation. Therefore, opioids should only be taken for short periods of time where needed. Gabapentinoids, like pregabalin and gabapentin, target and bind to the alpha-2 delta subunit of voltage-gated calcium channels. Through binding to voltage-gated calcium channels, gabapentinoids inhibit calcium influx by reducing the numbers of these channels reaching the cell surface. This will cause reduction in the likelihood of an action potential being fired to continue relaying the full pain signal, as well as inhibiting the release of excitatory neurotransmitters. Or in more simplistic terms, gabapentinoids bind to voltage-gated calcium channels, preventing the inflow of calcium by reducing the availability of these channels, which means the full pain signal cannot be reached to higher brain centers. This causes the suppression of pain transmission. Gabapentinoids are advantageous as they are not addictive. However, the drug initially works, but its therapeutic effect will dampen over time, or in other words, the effects are refractory. However, this does not happen in all patients. There are also some serious central nervous system side effects. Depression is associated with chronic and neuropathic pain. These individuals believe they are alone and nobody and nothing can help them. Therefore, patients will often take or be given antidepressants like tricyclic antidepressants that target psychological pathways as opposed to pain physiological pathways. They stimulate the production of endogenous opioid peptides, serotonin and noradrenaline, which exert an analgesic effect and alleviate depressive behavior. Although pharmacological interventions may be enough for some, they do not work for everyone. Individuals suffering from chronic or neuropathic pain often use a combination of approaches. Other approaches available to them include electrical stimulation and cognitive therapy. The most commonly used electrical stimulation method is transcutaneous electrical nerve stimulation, otherwise known as TENS. It entails the use of a device which generates pulsed electrical currents through electrodes placed at the area of pain. These currents activate primary afferent fibers that activate opioid receptors, specifically mu and delta opioid receptors, which stimulate endogenous opioid production to exert an analgesic effect. TENS is safe to use, inexpensive, and readily accessible. However, just like any other treatment approach, there are limitations. The limitations of TENS are tolerance, which decreases its effectiveness. The final intervention is the cognitive approach, such as behavioral therapy and pain management programs. Those with pain often develop depressive behavior. Those with neuropathic or chronic pain believe that pain is a debilitating disease, bringing prolonged misery and is impossible to treat. Behavioral therapy involves a psychologist and the patient, whereby the psychologist aims to help the patient overcome these negative thoughts, replacing them with more positive beliefs. Therefore, it targets psychological pathways. It will involve educating the patient about the condition, relaxation training, and therapy. Behavioral therapy has shown to increase patient pain management and quality of life. However, as pain is a subjective sensation, the approach does not work for everyone. Another cognitive approach is pain management programs. These programs normally involve a group of 8 to 12 people who meet up regularly over a short period of time, ranging from 2 to 12 weeks. These sessions are put together by pain specialists and are run by a multidisciplinary team. Members of this team may include psychologists, physiotherapists, occupational therapists, doctors, nurses, and more. The programs provide a space for people to share their experiences about pain. They often entail physical exercises, therapy sessions, and skill training. These programs have shown to increase quality of life and participation in daily activities. As pain is a subjective experience, it means no one treatment will work for everybody. What may work best for one person might not work as well for another person. Therefore, people will use a combination of treatment approaches to find out what works best for them to help manage their pain. But the current model of care of pain is suboptimal for some and a failure to many. Change needs to happen, and it needs to happen now. The care of pain needs to take place outside a hospital and medical setting. Dealing with pain in a hospital and medical setting often gives the illusion to the patient that their pain can be fixed as long as they keep going to these medical environments. However, pain is also a social problem, and therefore it needs to be dealt with in social areas. Care of pain needs to take place in less pressurizing, fast-paced environments, like hospitals, and move into more familiar social environments for the patient, such as their favourite cafe, home, place of work, community centre, library, and more. The care of pain needs to be accessible for as long and often as a patient needs. They should not just be entitled to the short period of time programs provide them with. People with pain often have a prolonged diagnosis before their pain is identified as being long-term by their GP, and eventually they are directed to pain clinics. This process can take up to 6 months, if not much longer in some cases, whereby they are given appropriate available treatment approaches from there. After the course of their treatment, people must go and learn how to deal with their condition in their ordinary lives. Most find living with pain becomes increasingly difficult again without the ongoing support. People with pain often re-enter a frustrating and time-consuming repeated cycle of diagnosis, treatment, and management throughout their lives, with every referral taking huge amounts of time as it takes months to get referred to specialists. Meanwhile, these individuals are needlessly suffering with their pain. This cycle must be broken. The care of pain needs to allow patients to have ongoing or occasional access to clinical support. GPs currently do not have direct access to pain consultants who are experts in the field. GPs can only refer patients to a pain clinic, and once they are seen there, patients may have the chance to speak to pain consultants about their condition. This process can take up to 6 months, if not much longer in some cases. This needs to change. Chronic pain is a long-term condition. Patients living with chronic pain require ongoing care, not just an episode of care. We need to make GPs the centre for people to go with pain, as they know us best, care for us, and have comprehensive records regarding our conditions. Upon suspecting chronic pain or for general management, GPs should have access to pain consultants to discuss their patients' needs. They should also be able to refer patients to pain psychologists, pain physiotherapists, pain occupational therapists, who need to be located within the community. Patients will hopefully then have the peace of mind and clarity about how to move forward. Furthermore, GPs need specific funding to allow them time for their annual review with patients living with pain. These changes will reduce the time patients have to wait to receive a proper diagnosis, prevent them re-entering the repeated cycle of diagnosis, treatment, and management throughout their lives, and get them to begin learning how to self-manage their condition. To support Pain UK, please like their Facebook page, which is Pain UK. Subscribe to their YouTube channel, which is Pain UK. Sign up to become a member at Pain UK, or donate to Pain UK. All relative information about how to further support the cause can be found on their website, which is www.painuk.org.